Good afternoon to everyone. Good afternoon. We are Group B. These are our group members. This is the table of contents. For our general data, this is a case of RF who is 32-year-old female, married, Filipino, Roman Catholic and is a resident in Binloc, Dagupan City and she works as a teacher. The date of consultation was 1st October 2021. Time of consultation was 11 a.m. The chief complaint is bleeding. For the history of present illness, the patient came with vaginal bleeding, which is colored red, and she has pain. She noted that the pain was 5, and there was no other vaginal discharge. No rashes were noted. She is not going under any medications. No history of contraceptive pills usage. She has irregular menstruation interval of 2 to 3 months. Duration is 3 to 5 days and amount is 3 to 5 moderately soaked pads. She has no headache and no nausea, no vomiting but has hereditary hypertension.
Okay, is that really part of the HPI, history of present illness, the menstruation, menstrual history, and the hypertension, etc.? Diba? It's not HPI, history of present illness. You concentrate on the bleeding. Was it about the vaginal bleeding?
Okay,
Diba?
Pooja. Thank you.
And the menstrual cycle, the menstruation part should be part of the menstrual cycle, and then hypertension should be part of the past medical history, right?
Yes, Pooja.
Okay, so with regards to vaginal bleeding, what should be included in there? The
She has
amount.
no.
Patient can be, when did it start? The onset. When was the onset? It's not there. Right? You forgot the OPQRST, ba? O, the onset of vaginal bleeding. P, presentation. Is it profuse, minimal, moderate, minimal? Right?
Yes, Pooja.
How about the amount? Is it
So,
soaking a pad or not? That should
yes,
be part of it. Mm. Or anybody, what should be asked about vaginal bleeding in this case, which are lacking in the history? So onset-wise, it is important to determine, because by that you will be able to identify the chronicity or acuteness, right? How about the amount? It's important also because it may cause complications like what? Homal.
yes, Pooja.
What is the anticipated complication of bleeding, vaginal bleeding, in regards to the amount?
Any internal organ bleeding,
Ha? Internal organ bleeding, vaginal bleeding ka eh?
like any cancer.
Cancer agad? The most common consequence or complication of vaginal bleeding. Anybody? Sander.
Doc, it will result to decrease in blood volume po, Doc.
So, anong mangyayari?
Hypovolemic yung patient.
Anemia po daw.
Oh, anemia. Ano pa? Shock as to decrease blood volume. Di ba yun muna that you're going to think of? By talking about the amount, you should be asking how many pads were soaked. Is it moderately soaked? Fully soaked? Diba?
Is moderately soaked po daw.
So, it should be placed in there. Oh. Ano pa ang importante sa history with regards to vaginal bleeding? Anybody? Is it important to ask for the precipitating factor?
Yes po, Doc. It's important po.
Oh, it wasn't asked. Diba? P, precipitating factor. Oh. What precipitating factor could you think of with regards to vaginal bleeding?
Doc, some forms of medication and or contraceptions po.
Okay, or ano pa? Trauma, pwede ba? Trauma? Oh. Coitus, pwede rin yun with postcoital bleeding. Mga ganun. So, it is important that the patient came in with, quantify the vaginal bleeding. Came in with profuse vaginal bleeding, profuse vaginal bleeding. Soaking about ilang pads in 24 hours. Which is started 1 day, 1 week, 1 month, ganon. And then, while after, mga ganon, after ano tawag doon? After sexual intercourse, pwede na ganon for the precipitating factor. OPQ. Quantity and quality. So, we have touched already. R. Ano yung R for vaginal bleeding? Anybody? Siyempre, hindi radiation. Anong R in vaginal bleeding? Marami kayong pwedeng mnemonics kasi, pero that's one way that you had completed to put adjectives to your vaginal bleeding. Anybody? Pwedeng recurrence ba yung R?
Pwede po, Doc.
Oh, pwede, di ba? This is which occurred for the first time or for the second time. Oh, that's for the recurrence. Oh, ano pa ang R sa vaginal bleeding? That's very important because that will show you the chronicity or acuteness of the vaginal bleeding. So that you would anticipate other complications na. Kaya nga nun, anemia, shock, etc. Even heart disease, kasi kung chronic na yan, you might consider cardiac problem in this case as a complication of chronic anemia. S. Anong S sa vaginal bleeding? Anybody?
Doc, severity of bleeding po.
O, severity of bleeding. Pwede. So yun nga, it's either profuse, moderate, or minimal, or soaking a pad, maternity pad, and regular napkin. It's very important to identify or ask, confirm what was used. Baka mamaya um, soaking an adult diaper, ubus na ang dugo niya, or a, a neonatal diaper. Some women would be using that. And that's when you would mention also the presence of blood clots. Kasi having blood clots, when you measure a blood clot, it is double the amount of a non-clotting blood. So for example, a blood clot amounting to about a cup. So that's, for example, the cup is around 250. So the actual measurement of a clot, which is a cup of 250, then it is 500 cc. Tandaan nyo yun ha, pag clot times 2. It's times 2 ang estimation nun. Okay? So it's very important to know the severity. And when it comes to vaginal bleeding, yon. Other than that, you have to take note of the presence of clots. And you can ask, sa isang baso ba, half a cup? They can really quantify, estimate. Okay? Or sometimes they would say, as big as my fist. So you have to look at the fist. If it's usually ang fist, like my fist, mga ano na yan, 250. So, 500 cc yun. Okay? PQRST. T. O, T na tayo. Anybody? Anong T sa vaginal bleeding?
The
O, timing. Okay? Somebody texted timing and? Okay, timing and treatment. Okay, pwede. So, you have to ask when did it occur? Or is it along with the regular menstruation or intermenstrual cycle? That's a different story. Right? Okay, and then the treatment or what could have been the treatment that she'd been using that she responds with, or despite of the treatment, the dosage, the frequency, the dosage, and the reaction or the response to it, if she's responding to the treatment or not. Okay? PQRST. Meron pa ba? Meron pa ba tayo? Okay, so by following the PQRST in this vaginal bleeding, it would be a long paragraph now, right? So, this is the case. The patient came in with, for example, moderate vaginal bleeding, soaking, 3 diaper, pediatric, neonatal diaper, baby diaper, in 24 hours for 3 weeks now. O, di ba? So, ano na yung P natin? O, yun. Ang haba-haba na nun. Next time, ha? It's not, history should not be, in this case, should not be just 2 letters. Kasi, okay. You just gave us 2 sentences, di ba? Oh. So, in this case, if you would file the PQRST, at least you will have 7 sentences with just the vaginal bleeding only. To add up, you can include even the other signs and symptoms. Other signs and symptoms that you should be asking in association with vaginal bleeding. Sige, the group of Kumal, give 1 by 1 each. Signs and symptoms. Because other than the PQRST, kung yung S na yung severity, then you have to ask Also, associated signs and symptoms. The pertinent positive first. Sige, pertinent positive first.
She mentioned that she has no headache, no nausea or vomiting.
What
And
else? Other than nausea, vomiting, headache, ano pa?
uh, she also mentions there was no vaginal discharge and no fever was.
Of course, you will not have another vaginal discharge with bleeding. How could you identify? It's all red, right? Oh, can you really, um, can you really imagine how could you have another kind of vaginal discharge on top or together with vaginal bleeding? Diba? You cannot identify. Agree?
Yes, Pura.
Oh, what's other members of the group? What's the more important to sign and symptoms to ask, to confirm?
Any itchiness or dryness. Pura.
Chines, nagdudugo ka. Hello, extend your imagination, children. She's bleeding, vaginal bleeding. Itchiness ba? O, sige, nearest to bleeding. What will happen? I think we have discussed this already before. O, sige. Vaginal bleeding, come on. Maybe itchiness, dryness, that's the last thing that will happen. Pero together with vaginal bleeding, that you should be asking, pertinent positive or negative, that you should be confirming. Aliana,
Doc, can we, if, can we confirm if the bleeding po, has unusually long periods or kung ilan days na po siya nag-bleeding?
we've tackled that one already. I'm asking about signs and symptoms, associated signs and symptoms with vaginal bleeding. We have described the vaginal bleeding already, or PQRST. Now we're going to put that as associated signs and symptoms. Imagine a patient who is having vaginal bleeding. Ano? Ano kaya mangyayari? What will you think of? Think from head to toe. Sige.
Dizziness po, Doctor.
Dizziness. Di ba nga? Oh, mahihilo ka na. O, dizziness. Anong next?
Pallor po.
Pallor. O, next.
Abdominal pain po, Doc.
Abdominal pain. Sige, next.
Difficulty of breathing po.
Difficulty of breathing because of anemia na. Di ba? O, ano pa? Physiology. Oh, pag may bumabagsak na ang hemoglobin mo, kulang anemic ka na, what would be the body's reaction? As symptoms, signs and symptoms. Go. Oh, hello?
Hypothermic.
Hypothermic, cold clammy. Oh, sige pa, ano pa? Go. Ang dami niyong dapat tinatanong dito.
Weakness, Doc.
Weakness. Ano pa?
Palpitations po.
Exactly, palpitation. Di ba? Palpitation. Together with palpitation, ano pa?
Um,
Ano ba? Bakit kayo nagpapalpitate? Bakit kayo nagpo-cold clammy? Because of anemia, chronic anemia, di ba? O, imagine that. Ano mangyayari sa heart niya? Bradycardic ba o tachycardic? Di ba?
Tachycardia.
Tachycardic and
Yes po.
palpitation, they go together. What will happen? Pag ganun na yung nagpapalpitate siya, what will happen to the heart? It will have cardiac enlargement. Ano mangyayari sa cardiac enlargement? How about the tolerance to fatigue? Sige. Easy fatigability. Diba? There would be easy fatigability, right? See, from head to toe, nahihilo ka. If you meet a patient who is having vaginal bleeding of any age, okay, ang woman siyempre wala namang lalaki na may vagina, no? Vaginal bleeding of any age, you have to take note or have to confirm from head to toe. Are you having dizziness, lightheadedness, blurring of vision, right? Difficulty of breathing, namumutla or pallor, special circumoral, right? Ano pa? Cold clammy, palpitation, dyspnea, easy fatigability. So, pababa ka na. Abdominal pain, yes, maybe to rule out other causes of anemia, like um, hemorrhage secondary to whatever in there that includes the GIT. Ano pa? So other than the itchiness, etc., that would be the latter signs and symptoms because of irritation, maybe. But the more important thing to confirm would be the immediate or more morbid signs and symptoms that you have to address. Right? Pag nahilo yan, nabango, it will have a head trauma. Right? Yung mga yun. Okay? Or with cardiac problem already, you might not be able to correct the cardiac enlargement. Ganyan. Oh. So you see now? So with vaginal bleeding, this paragraph would be a long paragraph now. So the patient came in with moderate vaginal bleeding, soaking dada, which started 1 week ago to di ba? With, ano pa, self-medicated, for example, with ganito, ganyan, which afforded no relief. Other signs and symptoms, other than the PURST, sunod mo, other signs and symptoms such as there were no other signs and symptoms such as, sasabihin mo na, dizziness, blurring of vision, da. You have to mention that. Okay? Sige, proceed. History pa lang, dapat may mahaba yan.
For the past medical history, the patient did not have any childhood illness, unrecalled immunization. She did not have any history of accidents, past hospitalization, trauma, or major illness, or did not exposure to radiation or toxic chemicals. But she has mentioned she had a surgery in her past. Also, she has noted that she has food allergy to chicken, but no known allergies to medication, and she has hereditary hypertension.
Okay. You always start your sentence with she. We're not talking about any other person, but she. So, what I mean is that I advise that you make the past medical history more comprehensive and concise so that you will not keep on repeating those she has. Okay? Next. Take it yun, ha? Proceed.
For the family history, patient's father is 65-year-old with hypertension. Her mother age is 59. Also, she has hypertension. She has two brothers with no illness noted. Diseases with hereditary tendency is hypertension and no known communicable diseases. There is no history of cancer. No other members of the family has the similar symptoms.
Oh, summarize.
Both the parents have hypertension. She has two brothers with no illness noted, and hereditary disease is hypertension. There were no communicable diseases noted, and she has no history of cancer, and in also her family members there is no history of cancer for her, and there are no other members having the similar symptoms like our patient has.
Anybody, help Kumal to summarize. Nungay, kasi ang gulo eh. Hello? Oh, summarize it. This is not the best way to present the the family history. Can somebody rephrase it? Okay na ba kayo dyan sa family history? Are you okay with it? How it was written? Tulungan na ninyo ang grupo ni Kumal.
Try lang.
Sige, go ahead.
Patient's father and
Listen.
who are 65 years old and 59 years old respectively are diagnosed with hypertension. No familial history of hypertension, communicable diseases. No familial history of communicable diseases and cancer with the other family members.
Sige, di ba? Much better if you if sige. No heredofamilial diseases like cancer, TB. Anya pa, ay hindi familial. Oh, tama. Familial pa rin ang TB kasi they live together. Diabetes, bronchial asthma, except for hypertension. Oh, tapos. Di ba? Oh, next. Proceed.
For the personal and social history, the patient is the last among the three siblings with two brothers. He is graduated high school and is presently working as teacher. He is married to X and he is a businessman. He is a non-smoker and non-alcoholic beverage drinker. He has no food preference and has no allergies to drugs but is allergic to chicken.
Ano yung kasama ba ang allergy sa ano? Is the allergy included in the personal history?
Yes, for her.
Is it included in the personal social history, the allergies? Anybody? No, di ba?
That could be po in
You should know where you should be
medical
placing.
history.
Oh, past medical history. Okay. It should be part of your past medical history. Okay? Oh, sige. Next.
For the menstrual history, the patient's menarche is 10 years old. He has an irregular menstruation interval of 2 to 3 months and usually lasts for 3 to 5 days. He used 3 to 5 pads per day, which is moderately so, and the patient does not experience dysmenorrhea. Her LMP was on July 2021, exact date was not known. For the sexual history, her age of first coitus is after marriage. Sexual partners 1. Current symptoms, she has no vaginal discharge or we need to ask for transmitted infection. For the OB history, the patient gravida is 0. Gynecological history, no gynecologic illness is found. Did not have any past gynecological operation. We need to ask for hormonal therapy and past HPV vaccination. For the review of symptoms, uh, he, for the skin, head, eyes, ears, nose, throat, there was no any.
Oh, next na lang. Next. Never mind the ROS. We mentioned a while ago na yan. KP.
Uh, for physical examination, upon examination, the patient is conscious, coherent, and oriented to time, place, and person. She can cooperate well during the interview and physical exam. For the vital signs, temperature is 37.8 degrees Celsius, respiratory is 20 cpm, and heart rate is 92 pm, and her blood pressure is 100 by 90. The anthropometric data is her weight 60 kgs and her height is 5.2 and BMI rate is 24.1. For the skin, normal, no gross lesions or any normal pigmentations. Thus, Calvas is good counter and no deformities or no repressions. Homosexually good hair and distribution. Eyes are pinkish purple conjunctiva antrica sclera. In ear also no problem. No ear deformities or improper alignment or negative discharge. No symmetrical, no deviation on us. No anterior neck mass, no cervical lymphatic plaque. Uh, Breast, bilateral symmetrical breast, no nipple discharge, no tenderness, muscle, no axillary lymph nodes. Chest and lungs, symmetrical chest expansion, no retractions, clear breath sounds, no whiz or crackles. Heart, point of maximal impulse at the fifth IC line. No hives, no thrills, regular rhythm, no murmur rhythmic. Let's come to abdomen. Abdomen is flat with normal active bowel sounds. Percussion, no normal tympani, tender or epigastric area. Soft and sapphire without scar. So to the extremities, visible joint swelling, no visible joint swellings, no limitation of movement, good range of motion in the hands, wrists, elbows, shoulders, spine, hips, knees, no deformities. External genitalia, no mastications noted, no legal varicose styles, and cortisals are necrosals noted. is abdominal uterine bleeding. Silent features. A 32-year-old female. She came with heavy bleeding and she have pain and she have amenorrhea, heredity of respiratory hypertension, and she have food allergy. Abdominal uterine bleeding is a common diagnosis, making up 5 to 10% of cases in outpatient clinics. Most cases are associated with involuntary menstrual cycles. Adolescents and perimenopausal women are particularly vulnerable. About 20% of affected individuals are adolescent age group, and 50% of affected individuals are aged 40 to 50 years.
Come again, what was the LMP? Pati ako nawala na sa imaginary patient nyo. What was the LMP?
2 months ago.
July 20, 2 months ago. Oh, why your consideration is AUB?
Because she has irregular bleeding also for the menstrual cycle.
So LMP was 2 months ago. And then now she's having bleeding. AUB? Is AUB your primary consideration? Other members of the group 3. Ay, group 3 ba kayo? Group 3? Hello? You have amenorrhea of 2 months, and now she's bleeding. Is AUB the first thing that comes into your mind? What should be your first consideration in this case? Amenorrheic for 2 months with vaginal bleeding. Looking at that, 32 years old with vaginal bleeding and history of amenorrhea. Ano? Come on! Hello? What would be your primary consideration here? Is it AUB? Kasi it would be useless to go on with the discussion if you were not able to clinch the more important diagnosis. Hello? Ectopic pregnancy because of the pain. But your pain was not further described in OBQRST. Do you have a description of the pain?
She mentioned that pain was grading 5 severity.
What else did you ask?
She mentioned the color. 3 to
Um,
5 pads moderately soaked pants of powder.
okay, if it is ectopic, is it moderately soaked?
In few cases, they are chance powder.
Why will you have vaginal bleeding in the first place in ectopic pregnancy? So you see, history, PE alone, or by history, most of the diagnosis and you're ruling in diagnosis and differential diagnosis and ruling out as well. So by um, putting subjectives adjectives on your um, vaginal bleeding and pain that will differentiate now, you are going to rule out, rule in, moderate in flow, the vaginal bleeding, is it a characteristic of, is it a factor to rule in ectopic pregnancy?
In the sexual history, there was no mention about the recent sexual contact.
What?
In the sexual history product, there was no recent
Oh,
contact.
there was no reason. So what does it has to do with the one that we're discussing about vaginal bleeding and pain? It has nothing to do now. The sexual history. You didn't get my point. You said the bleeding was moderate. Moderate bleeding. Is it a
Yes, for
part of the diagnosis basis for ectopic pregnancy? The patient with amenorrhea, 32, moderate bleeding with pain and amenorrhea, but the bleeding was moderate. Ectopic ba?
no point.
Can you think of another condition that would give you moderate bleeding other than ectopic? Mm, when you read something, you have to digest what's in it. Mm. In ectopic pregnancy, you will have minimal bleeding, not the moderate and soaking a pad most of the time. Why?
There will be a severe bleeding product in that topic.
What severe? There will be there will be severe.
Severe bleeding and also there will be a sharp pain product.
No, we're talking about bleeding. Don't jump to another thing. We're not yet done. We hadn't established yet the bleeding.
Severe bleeding product.
No, vaginal bleeding, you will not have profuse or severe, but it's not described as severe. Profuse bleeding in ectopic pregnancy. Allah. Because you see, ectopic pregnancy, you will have pregnancy and other than in the endometrium. But the endometrium will thicken and it will have decidual cast. If you have decidual cast, it would not be as thick as the usual thickness of a intrauterine pregnancy. So the bleeding you expect in ectopic pregnancy would not be profuse nor moderate. It would just be minimal. Nakuha niyo ba? Usually, ang ectopic kasi minimal and because the endometrium did not really develop a decidua, but just a decidual cast. Nakuha nyo ba? So here in your history pa lang, in your history, you should be ruling out now ectopic. Kasi sabi niyo moderate bleeding eh. Oh. So what conditions? So ruled out na ang AUB, ruled out na ang possible ang AUB but it has amenorrhea. Will you have amenorrhea in AUB? Abnormal uterine bleeding, more of ano, 'di ba? Frequent, more of positive, prolonged and profuse and heavy menstrual bleeding, right? Oh, ruled out na rin ectopic. So what other condition that would point out to these salient features that you have here? And to reiterate that the bleeding is moderate with pain. Oh, anong consideration nyo dapat dyan? Hello? Wala na naman kayo picture. Ako rin. Mahina ang net namin dahil may nanonood. Hello? Oh, can you think of another diagnosis? Possible diagnosis? Better diagnosis on these salient features that you had presented. Hello! Come on, people, think! O gutom na kayo, dinner time na, wala nang maisip. Which is the history, ano pa? Oh, we should rule out here topic. Kasi moderate yung bleeding niya eh. Then we should rule out AUB because of the history of amenorrhea. So nandun na kayo eh, she's pregnant. More of pregnancy ito. Wala na? O sige, 65 na ang grade. What condition will give you the salient features? 32, moderate bleeding, with pain, amenorrhea, ano? Anybody, tulungan nyo na nga sila. Ay, naapo.
PCOD product.
What?
PCOD.
Ano daw? P?
PCOD product.
Pregnant nga. PCOD? Polycystic ovarian disease. You will not get pregnant usually. They are infertile eh. Aww. Okay, even if she is having irregular menses, the fact that she had amenorrhea, you have to rule out first pregnancy, okay? What kind of pregnancy? Is it intrauterine or extrauterine? So you mentioned already extrauterine, which is ectopic. We ruled out ectopic because of the moderate bleeding. Okay? You will not have moderate bleeding to profuse bleeding in ectopic pregnancy. So you go to intrauterine. Do you get it? What kind of intrauterine pregnancy now that she's now bleeding? Moderate bleeding with pain. Oh, give me intrauterine bleeding, intrauterine pregnancy with bleeding and pain. Sige na.
Miscarriage.
Again? What was it? Ano daw? Ala. Everybody is hungry now, wants to eat dinner. Come on. Miscarriage ba ang sinabi mo? Miscarriage. What kind of miscarriage? Oh, moderate bleeding with pain. Oh, ano na? What kind of miscarriage?
Incomplete miscarriage.
More of incomplete miscarriage. What should you have asked in the history to support your claim of incomplete miscarriage? That's what you failed to ask. Passage of meaty materials. Kung incomplete. Okay, if there's no passage of meaty materials, then that would be what kind of miscarriage? Possibly.
Threatened miscarriage.
Threatened miscarriage or inevitable miscarriage. Yun. Okay, pag minimal, with no passage of mas of meaty materials, more of missed abortion or missed miscarriage. Do you get it? So you see, it boils down. All it boils down. It helps a lot in your diagnosis if you are so detailed in your history taking. So history taking really would give you the diagnosis. You will, with that, you will rule in and rule out your differential diagnosis. Okay, sige, proceed. So anong nangyari? You flash the succeeding slides.
That's it.
EUB talaga diagnosis ninyo. Okay. So anybody who has amenorrhea in the reproductive age, even beyond outside the reproductive age, okay, because children may get pregnant, and even perimenopause will get pregnant. Okay, as long as they are menstruating or bleeding, then you should be ruling out. Remember this: the first thing that you should rule out or consider would be pregnancy. And then what kind of pregnancy? Is it intra or extrauterine? Depending on the history that you took in your PE. Okay? Oh, remember that. Oh, comments, violent reactions. May comments ba kayo? Sige, next na kung wala. Next case.
So good evening po. We are the subgroup 3 and this is our case. Next slide. Here's the table of contents. Next po. Next. 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 And for the general data, so this is a case of MR, an 18-year-old female, Filipino, single, and independent siya. She was born on December 25, currently residing in Calasiao, Pangasinan. She sought consult for the first time, and she sought consultation, sorry, for the third time last October 1 at 2 p.m. Next slide. For the chief complaint, uh, masakit ang pag-ihi or dysuria, or the history of present illness. So, patient had two previous consultations done with the same complaint. However, it is of unresolved dates. 2 weeks prior to consultation, the patient experienced suprapubic pain on urination with a pain scale of 8 out of 10, non-radiating and alleviated by her self-medication of amoxicillin. She urinates about six times a day. The suprapubic pain was accompanied by fever. No other associated signs and symptoms such as bleeding and discharges were noted. For the past medical history, patient has been diagnosed with asthma and currently taking fluticasone. However, of the dosage and the frequency was not noted. Also diagnosed with UTI in her previous last consultation, which she self-medicated with amoxicillin. Has an unrecalled childhood immunizations and a known allergy to seafoods. She had a surgical procedure done in 2018 to the right arm due to fracture.
Next would be for the menstrual and sexual history of the patient. Next slide, please. The patient's menorrhagia is an 11-year-old. She had a history of irregular menstruation with an interval of 1 to 2 months. At present, the patient is having a regular menstrual interval, which lasts 2 to 5 days and usually uses 2 to 3 pads per day, but not fully so. Menstruation is accompanied by dysmenorrhea and takes methylenic acid to relieve the pain. Her last menstrual period was on July 2022. Next slide. For the sexual history, the patient was 16-year-old at first coitus and only had one sexual partner. No birth control methods such as condoms and pills are being used. Next, for the obstetric history, the patient is monogamous. Next one. Next, for the family history, patient's father is 50-year-old and mother is 55-year-old. Both of her parents were diagnosed with hypertension and takes losartan as their maintenance medication. All siblings are diagnosed with hypertension as well. No other history of heredofamilial diseases such as cancer, blood disorders, and respiratory diseases. Next, for the personal and social history, the patient is single and resides with her parents and six siblings. She is a high school graduate and, due to the current pandemic situation, works as an online seller. She started smoking 3 years ago and occasionally smokes 5 sticks per day with 0.75 pack years. Occasionally drinks beer and does not take any illicit drugs. Takes 3 meals a day with vegetable as her main component of diet, drinks coffee about 3 to 5 cups a day, and also takes multivitamins and exercises regularly and with a regular sleeping pattern of 8 hours at least.
So for the review of systems, next slide please. There's no any significant findings aside from our patients having fever. Next slide. Next slide. And dysuria or the difficulty in urinating. So next slide please. Back. So next slide please. Okay, so next slide. So for the physical examination of our patient, next slide. So upon examination, the patient is conscious, she is coherent and oriented to time, place, and person. She cooperates well during the interview and physical assessment. Next slide. So the vital signs of our patient, temperature is 36 degrees Celsius, respiratory rate is 22 cycles per minute, which we considered as tachypneic. Heart rate is 80 beats per minute, normal. The blood pressure of our patient is 190 over 110 millimeters mercury, hypertensive. Next slide. So for the anthropometric data, the height of our patient is 5'3", the weight is 42 kilograms, the body mass index is 16.4, and it is considered as underweight. Next slide. So head, there's no significant findings here. The skull is proportional to size of the body or normocephalic. Prominence is felt in frontal, parietal, and occipital area, and there's no any masses or lumps, nor tenderness noted. Next slide. As for the neck, it is proportional to the size of the body and head, also symmetrical and straight, and our patient was able to move sideways. There's no lesions seen or any jugular veins are not distended, and upon palpation, there's no lumps or any masses nor tenderness. Next slide. So for the eyes, there's no significant findings. The eyes are parallel to each other. They are symmetrical with normal visual acuity. Also, the eyeballs are not protruded. The sclera is non-icteric. Lacrimal gland is not palpable, and they are not or non-tender. So there's no paleness of conjunctiva noted and any other abnormalities. So for the ears, they are normal and also symmetric. The outer skin is same as the surrounding area. Also, there's no swelling or any redness or discharge that are noted. Next, so for the nose, it is normal and it's symmetrical. There's no wounds, no lesions, and any inflammations. Also, there's no tenderness and congestion noted. And also, the sense of smell of our patient is intact. Next slide. So for the mouth and throat, our patient has well-defined lip margin. Her gums are pinkish in color. Oral mucosa is not dry. There's no swelling or any discharge. So our patient is not wearing any dentures. Teeth are presented with no dental caries. The tongue is in central position, medium-sized, pinkish in color. It is moist, shiny, and freely movable. And there's no other lesions noted. Next. So for the chest and lungs of our patient, it is symmetrical with good expansion and no retractions. There are no deformities or no bulging or any retractions. On respiration, the skin is intact and it has a uniform temperature, bilateral symmetry of tactile primitus. Her lungs are resonant and there's no wheezes, bronchi, nor crackles that are observed. Next slide. For the heart, it's a dynamic precordium, no bulge or heaves. So our patient has regular heart rate and rhythm. Also, no drills and friction rubs or morphs. Next slide. So for the breasts, they are bilateral, symmetric, and inboard dominated. And there's so dark, no nipple inversion, no masses, swelling, or abnormal discharge, and there's no tenderness noted. So for the abdomen, no scars, no lesions, or any discoloration noted. And there's hypoactive bowel sounds. It's normal. So for the extremities, no visible joint swellings. There's no limitation of movement for our patient. She has good range of motion in the hands, the wrists, the elbows, or any or in other extremities. There's also no deformities or cyanosis. So with next slide. So for the salient features,
So for the salient features, we divided it with subjective and objective data. For the subjective, includes dysuria, suprapubic pain, dysmenorrhea, irregular menstruation, and smoking and drinking alcohol. For the objective data, the patient has a fever, tachypneic with 22 cycles per minute, and hypertensive crisis for the blood pressure of 190/100. Next slide. So our working impression is next slide. Acute uncomplicated cystitis. Next. So for the differential diagnosis of this case, we have five differentials, which includes urethritis, vaginitis, painful bladder syndrome, pelvic inflammatory disease, and nephrolithiasis. For the urethritis, we ruled it in since the patient is experiencing dysuria, but ruled out because of the urethral irritation and vaginal discharge. For the vaginitis, ruled in dysuria and polyuria. Ruled out vaginal discharge, pruritus, vaginal dryness, and dyspareunia. For the painful bladder syndrome, ruled in dysuria and polyuria, but ruled out for the no signs of infection. Pelvic inflammatory disease, ruled in fever, dysuria, and suprapubic pain. The ruled out of vaginal discharge and cervical tenderness. And for the last differential, which is the nephrolithiasis, ruled in fever, dysuria, and suprapubic pain. The ruled out because without flank pain, renal colic, and hemophilia. Next.
So for the epidemiology,
Oo, yung diagnosis ninyong iba, hypertension. So, dapat, diagnosis ninyo, diagnosis 1, or problem 1, problem 2, problem 3, di ba? Dinisregard na niyo, will you have hypertension with the acute, ano yon? Diagnosis nyo? Bladder
acute uncomplicated cystitis.
cystitis. Oh, that's one. Problem 1 is acute uncomplicated cystitis. Problem 2, o kung hypertension, di hypertension lagay ninyo. How about the amenorrhea? Do you have amenorrhea in acute uncomplicated cystitis or hypertension, or would it be another problem? Nakuha? Okay, so ibig sabihin you could have several working impressions or could be one impression. If they are correlated, it could be, kaya kunyari, acute and complicated cystitis secondary 2. Kung may secondary 2 siya doon. Right?
Yes, good.
Okay, next time. Oh, remember that. Do not disregard or all other signs and symptoms that are not, it does not fit into your working diagnosis. So think, is it part and parcel or not? Or is it a separate entity or separate diagnosis? Then if it is a separate, then you can put there diagnosis 1, diagnosis 2, diagnosis 3. Or if you could combine the three, then secondary, secondary, secondary. Or problem one, problem two, problem three. Likewise, in your differential diagnosis for problem one, two, three. Okay? Next time, ha?
Yes po,
Oh,
thank
Yes
you.
po,
yon.
Doc.
Sige, proceed. So, isa lang ang diagnosis ninyo. Okay, proceed.
So for the epidemiology, your urinary tract infection, in this case, your cystitis, your bladder infection, is the most common bacterial infection in an outpatient setting. Approximately 50% of all women develop UTIs sometime during their life, and by age 70, 10% will have recurrent UTI. Next slide. Radiology. So since it's an inflammation and usually it would be bacterially initiated. Your cystitis it's caused by primarily by your E. coli or Escherichia coli, uh, which is about 80 to 85%, and the others such as Pseudomonas, Proteus, your Staph saprophyticus, primarily your Staph saprophyticus. We can note this in UTI in your sexually active patients and your streptococcus and in your chlamydia. So next, for the pathogenesis. So first, these are the risk factors for UTI or cystitis. So again, your short female urethra, therefore allowing the easy access to the bladder, as well as your proximity to the vulva vagina, and rectum to the urethral opening, as well as the effects of sexual intercourse, and lastly, your loss of estrogen in other women, therefore allowing the rise of vaginal pH and permitting the colonization of your E. coli. Next slide. So these are generally the risk factors. So those are your iatrogenic, your drugs, your behavioral. However, for the sake of our discussion, we'll be focusing on your anatomic physiologic part, your urethral reflux, your female sex, of course, and your pregnancy. Next slide. So once the risk factors has been established, like what I said, there would be a colonization of bacteria, uh, presumably your E. coli, since it accounts for most of the cases, and there is ascension towards the bladder. Therefore, once there is ascension in the bladder, there would be colonization again to the urinary bladder by your E. coli through their bacterial fimbriae. These are attachments or these are extensions to their cell wall that permits the attachment of the said bacteria to the bladder epithelium. This will cause penetration, and it will once penetration happens, there will be continuous bacterial replication with biofilm formation, in which this biofilm formation would protect the bacteria from immune responses uh, by the patient. So this once it's all said and done, the bacteria has established its colony in the urinary bladder. There would be a recurrent UTI, which can precipitate dysuria, your frequency, your urgency, and your suprapubic pain, as felt by the patient in our case. Next slide. So again, this is a diagram depicting the colonization. So in this case, it actually discusses all uh, the ascension of the bacteria from your urethra towards your kidneys. However, for the sake of our discussion, we'll just be limited to the ascension to the bladder. Again, like what I've said, there is a uroepithelial penetration, and once penetration happens, there will be a subsequent replication and then biofilm formation and your infection ensues. Next slide. For the diagnostics, so for acute uncomplicated cystitis, it is actually diagnosed clinically. The presence of your dysuria, your frequency and urgency in the absence of your vaginal discharge, or any risk of STIs like your gonorrhea and your chlamydia. Additional testing does not aid. However, we can always request, for example, your urinalysis. Usually, it's midstream clean catch. Check for the leukocyte esterase, your nitrites, and your WBCs per hyperfilm. Again, culture may not be necessary since pathogens are predictable and since it's mostly E. coli. Next slide. Uh, This is from the Harrisons. So, four criteria for the diagnosis of AUC should be fulfilled. Uh, First one is the patients with dysuria, and this would already account about 50% of the probability of cystitis. And uh, this rises to 90% among patients who are healthy, non-pregnant, and with normal urinary tract. So for this case, we can order your UA. Again, taking note of the previously mentioned parameters, your CS, your culture and sensitivity, and your pelvic exam. Next slide. Uh, Previous slide. So again, this is the diagram for the things I mentioned earlier. Next slide. Thank you.
So next we proceed.
Okay. Wait. One thing that you had missed in your in your basis for diagnosis of AUC, you disregarded the fever. May fever siya, di ba?
Yes, po.
Yes po, Doc.
Yes. That's why I'm cutting you there because I want to emphasize that having fever in this case would make a big difference in your diagnosis. That will give a big point to rule in, which is the acute pyelonephritis. Higher, it's not just the bladder. Kuha? Kasi kung acute urinary bladder, kung cystitis lang, usually you don't have fever. But if it is acute pyelonephritis, you already have fever. Kuha? O, sige, almost there. Hindi umakyat. O, sige. Hindi umakyat yung pathogenesis ninyo, but yung diagnosis ninyo nag-stop na sa bladder. But if I were you, I would have at this point, we should be considering acute pyelonephritis more than the acute or cystitis only. O ha? O, sige, go on with your management.
So we proceed with the management. Next slide, please. So this figure here is was lifted from General Gynecology by Lobo, showing now the strategies for managing um, recurrent cystitis as with our case. So for the recurrent cystitis, first for reinfection, if woman uses diaphragm and spermicide, consider changing now the contraceptive method. So for urologic evaluation, not routinely indicated. So if it's less than or equal to 2 UTI per year, the patient or we must have the patient initiated therapy for the symptomatic episodes. But if it's more than or equal to 3 UTIs per year already, um, if it's temporarily related to coitus, we should have the post-coital prophylaxis. So the recommended regimen under this would be trimethoprim, sulfamethoxazole, and then we have here cephalexin of 250 milligrams, also nitrofurantoin 50 to 100 milligrams. So on the other side, if it's no relation to coitus, daily or thrice weekly prophylaxis is recommended. So for the recommended daily regimens, here we have trimethoprim 100 milligrams, also trimethoprim sulfamethoxazole, nitrofurantoin, norfloxacin, and cephalexin. As for the relapse, we seek occult source of the infection or urologic abnormality. And the treatment is longer, usually 2 to 6 weeks. So next slide, please. So this is another table lifted from Harrison's, showing now again the treatment strategies for acute uncomplicated cystitis. So as you can see on your left side are the drugs, the different drugs and their dose. The estimated clinical efficacy, the estimated bacterial efficacy, and their common side effects. So just a rundown for nitrofurantoin, um, the common side effects would be nausea, headache. For the trimethoprim sulfamethoxazole, this is the dosage that is recommended for this case. Also, the common side effects would be the rash, the urticaria, the nausea and vomiting. Also, we could also have here hematologic abnormalities as its side effects. So, fosfomycin is also indicated for the treatment. So, the common side effects would be just like the other drugs that are here. Or so also we have here the mesilinum, then also nausea, vomiting, diarrhea as its side effects. The fluoroquinolones is also there. For fluoroquinolones, however, the dose varies by agent. So common side effects also as other drugs, nausea, vomiting, headache. However, in fluoroquinolones, it could lead to drowsiness and insomnia. So also we some or other treatments are the beta lactam. So also for this beta lactams, those varies also by the agent. So here, next slide please. So another algorithm in treating or choosing an antimicrobial agent for empiric treatment of acute uncomplicated cystitis. So quick rundown. So for the woman presents with acute uncomplicated cystitis, if there's any absence of fever, those signs and symptoms. If yes, can one of the following recommended antimicrobials be used based on the availability or any allergic history, if any, and tolerance? So here we have nitrofurantoin, and then the dosage is also indicated there, 100 milligrams twice per day for 5 days. So avoid if early pyelonephritis is suspected. Or we could also have here trimethoprim sulfamethoxazole, and then the dosage is also indicated there. And then also fosfomycin. And then for the other side, if these signs or symptoms is usually or not present, consider alternative diagnosis. So there, it is indicated the pyelonephritis, the complicated urinary tract infection, and we must treat it accordingly. So continuation under the yes. So if we are done with this parameter, the upper box here. So if yes, or as you can see on the lower part, yes, prescribe a recommended antimicrobial. So this is actually based on the condition of our patient. If no, consider fluoroquinolone, that is resistance prevalence in high um, in some areas. So beta-lactam then or beta-lactam antibiotics. So here, avoid ampicillin or amoxicillin alone. So lower effectiveness than other available agents, and this require close follow-up of our patient. So next slide. So for the prognosis, so patients with uncomplicated cystitis typically have improvement of symptoms within 3 days after the initiation of the antibiotic therapy. So recurrent cystitis occurs in 25% of women within 6 months after their first UTI. So rate increases in women with more than one prior UTI. So complications are rare, especially in patients who are appropriately treated. Next slide. So for the prevention, so here are just some of ways or management that we could have or order in our patient in order for us or in order to prevent now cystitis. So maintain good genital hygiene, do not delay urination, abstinence or reduction in intercourse frequency. So if our patient is a spermicide user, consider a change to another method for contraception or infection prevention. So there also avoid spermicides and condoms with spermicides, which can alter the vaginal flora. So also plenty of fluids is warranted. Next slide. I think this is the last slide po, Doctor. Thank you po.
Okay, I want you to go back to your history. Flash your history. Okay, you go there. Enlarge ko ha. The patient experience Okay. Do you think this is really a recurrence of the dysuria or untreated first dysuria? What do you think with that? She self-medicated and alleviated by self-medication. Siguro temporary lang. 2 weeks with the patient experience, suprapubic pain on urination with pain scale, non-rejecting, and okay, she urinated. The suprapubic was accompanied by fever. So do you think, are you in this history, reading the history, do you think the suprapubic pain or cystitis is a recurrence?
Doc, yes po, Doc. Since she already had 2 previous consultation with the same um, complaint of having suprapubic pain on urination.
Is it okay? So recurrence sa inyo. But for me, it would be a spectrum, okay, or spectrum of the infection from simple UTI, cystitis, to pyelonephritis. Nakuha nyo?
Yes po,
So it's a continuous process. It's not a recurrence. It's just that it's na-alleviate siya, but she consulted again. So meaning there was no really alleviation of the condition, right? And even this time, she's having fever. So it had progressed, the infection, to pyelonephritis nga. Pwedeng UTIs, then cystitis, pyelonephritis. So it's a continuous or a spectrum or a continuum of the first signs and symptoms. Okay, next question. Is it complicated or uncomplicated condition this time? Looking at your history. Ano, sa tingin nyo, complicated at complicated? Kasi your diagnosis is uncomplicated, di ba? Looking at your history. Hello? Asan na kayo? Complicated at complicated?
Doc, is it complicated po?
Ano na? Ano? Ano na nga eh? Complicated at complicated para kumain na tayo. Gabi na.
Doc,
Doc, complicated.
O, see? By history alone, alam naman pala ninyong complicated eh. Complicated kasi parang failed ano siya eh, self-medication. Kasi dumiretso siya, lalong naging symptomatic. And by having fever, that points out now to a more severe infection. Nagre-react na talaga yung katawan mo in a systemic way. Fever kasi is systemic, right? Oh, sige. From your history alone, do you believe that it's only cystitis or went to the kidneys?
It already went to the kidneys po, Doc.
Oh, nag-ascend na siya sa kidneys. So, your final diagnosis and your other diagnosis. Yung diagnosis natin dito, Garot, is it still cystitis and complicated?
Complicated pyelonephritis po.
Oh, pyelonephritis na siya. O, other diagnosis. May other diagnosis pa ba tayo? How about amenorrhea and hypertension? Is it related with the pyelonephritis
Wala po yata mention.
or separate? So, problem 1, pyelonephritis. Number 2, diagnosis 2, anya?
Hypertensive crisis. Since the BP should
Okay, so it's a separate entity. Number 3, ano pa? Butis ba to? Hindi. Sa tingin nyo?
So po, Doc.
Kailan ba ang LFT niya?
July 22, 2021.
So, ilang days, amenorrheic? Ilang weeks, I mean. O 10 weeks. Pregnant or not pregnant? Shall we include in the diagnosis the pregnancy or not? Do na guys. Decide.
Maybe we can add to the
Ang diagnosis natin, acute pyelonephritis, hypertension type 2 ba? Stage 2, and rule out pregnancy, 8
Pregnancy.
weeks. Oh, sige. So, that matters now on the diagnostics and your treatment. Of course, you cannot give the usual quinolones for a pregnant woman. So, you will now take a look on the category, if it's category A or B for the treatment of the pyelonephritis. And ano na nga yung isa, hypertension. Hindi pwede ang ACE inhibitors. So remember that, hindi pwede ang ACE inhibitors when it comes to hypertension. Okay, any questions? Any questions? Wala. So I just want to emphasize in this case that in pregnancy, you can have also other diagnoses other than the pregnancy itself. It could be complicating the pregnancy or as secondary to pregnancy as a risk factor. So the pregnancy itself can enhance the occurrence of pyelonephritis as discussed with the anatomic changes. Also, it is the hypertensive crisis because of occurrence of estrogen, etc., etc. in pregnancy and yung placenta. Okay? Ayun. And then, in diagnostics now, it matters to include or rule out pregnancy as well as in the treatment of any condition at that. Any questions or additional reactions, clarifications? Uy, dapat ganun ay, ngayon na kasi, so, take note of that ha. When you take your history, you put adjectives. You have to qualify, quantify your chief complaint. You can start with OPQRST. Dagdagan pa ninyo yung acronyms na yung solution. Ano pa? Kung ano-anong acronyms, di ba? Just to describe the chief complaint. Huwag kayong madamot. That's why you had English in your pre-med. Make use of it. Okay? There are a lot of adjectives to describe a condition. And describing a condition will lead you to the right diagnosis. And to rule out, those should be ruled out. Nakuha? Okay? Sige. At tapos, other than that, while you're doing your history, you're already considering your most probable diagnosis na. Okay? So that's why you studied the basic pathology, and physiology, now combining in the clinics, in clinical case. Okay? Sige. Wala na kayong gutom na lahat. Sige, goodbye na, attendance na. Submit the attendance. Submit ninyo yung output nyo, ha? Sige, bye-bye. Attendance na garod. Done na? Wala na. Bye na. Leave na.
Thank you po, Doc.